body, and so today's talk is on fascia. And he travels very extensively and is taking a lot of time out of his schedule to come here to Boucher. He lives in Seattle, so he focuses on sports medicine. So, do you want to talk more about yourself?
Sure. Thanks. All right. So, yeah, I'm doing a quick talk today on fascia stuff, but really we can go any direction we want. I'm not stuck to that idea. So, like Mary said, thank you. My name is Ashok. Feel free to call me Ashok. I got in contact with the Sports Medicine Club here because I was part of the Sports Medicine Club down in Fascia. And during my schooling, me and another student from SCNM, we helped create 4 other sports medicine clubs around North America held in naturopathic schools. Because it just wasn't happening. You know, there wasn't a lot of stuff going on. Fascia had a great program. SCNM has a good sports medicine program. I didn't know much about Boucher, and I got a little bit of contact back and forth with Paul, who was here originally doing some sports medicine stuff a couple years ago. And so there's so much that we can offer as naturopathic doctors in sports medicine and physical medicine, and there's so much more we can do. And I want to see us be able to do that. You know, I was fortunate enough to have mentors that were trained in. Oh, there you go. That's my family. Hi. Let's see if this comes in. Cool. Fascia and things. Yeah. So I wanted to just get some things going with. Let's do this. Oh, that's not what I want.
You're trying to do the bright now?
There we go. Let's pick that one. That did not work. You know what? Screw it. Yeah, so I wanted to get a few more things going and get people a little more excited about sports medicine. So I'm also a kinesiotaping instructor, certified kinesiotaping instructor, and right now the only naturopathic doctor in Canada certified kinesiotaping instructor because there's nobody else doing it. And so all the kinesiotaping stuff, if you're familiar with kinesiotaping, it's all being taught by either PTs or chiropractors. And it's like, cool, some of them are really, really good at what they do, and it's great. You can learn a lot. I would encourage you guys to learn from anybody you possibly can. I did a lot of that, from all sorts of different practitioners. But we have a philosophy, we have naturopathic principles, we have a view of looking at the body that's different. It is unique, and that should apply to everything that we do, not just primary care, not just herbs, not just pharmaceuticals, even sports medicine and physical medicine. We can look at everything we do, all modalities, all areas of practice, and look at it from the naturopathic scope. And so my goal is to actually talk about more things from that side of things and see how we can approach sports medicine in a more naturopathic way. So a few things. So I've been doing stuff for a while. Background is kinesiology, a lot of exercise, biomechanics stuff. I do a lot of stuff with that. Currently, I have a company I started back in during med school in Seattle, and we're now sponsoring Bastier's clinic. It's going to be the first sponsor of a naturopathic clinic with an exercise database, a patient handout database with videos, written descriptions, and pictures and handouts for patients to use and take home instead of be like, oh, you should do more like leg exercises, go do some squats and then send them home, and they get home and they're looking at a clip art picture you printed out for them. What do I do with this? So I put together a database with my business partner, and we're looking to get close to about 100 open source videos online about different exercises and slowly build that. And right now we're sponsoring Bastier Clinic with a pilot project to see them start giving these out more and get students a little more excited and interested in learning more about exercise rehab and exercise as a primary modality for basically every single condition you can think of. But that's a little more stuff going. Okay, I'm going to talk about this. There we go, let's do that. So I'm going to talk a little bit about fascia today. I heard it was a topic of interest here in the sports medicine world, and we can go down different routes with it. I've done a handful of things with fascial research, fascial work, and the practical application as well. And I'm just going to talk a little bit about that stuff. But again, let's keep it like, I do a lot of talks and a lot of teaching and stuff, and I don't like to just talk. I do like talking, but I don't like to just stand here and talk forever. So if you guys have questions, or you want to start a discussion, be like, hey, I heard something different, that sounds weird, say it. Just tell me, and let's have discussions about this stuff, because that's when stuff is fun. So let's just go into this a little bit. So defining fascia. The Fascia Congress a couple years ago was in Washington, D.C. Before that, it was actually in Vancouver. So that was the 4th International Fascia Research Congress. And they tried to come up with a definition. We still don't have a very great consensus in the world of body workers, anatomists, surgeons, doctors, whatever, on how we can fully define fascia, right? Fascia is the connective tissue. We know what it is. We look at it, we dissect it, we open it up, we cut it out. Surgeons chop it up all the time. We work on it if you do any sort of myofascial work, massage, soft tissue manipulation, Graston type stuff, gua sha, if you're doing other things like visceral manipulation. Anybody here do visceral manipulation? Or learned it? No? Craniosacral therapy? Kind of. So both of those, I would say you're working on the myofascial system directly and indirectly. Yoga, I would say, directly fits into the fascial world. Acupuncture, the meridians, where do they sit? I would venture a guess that it is likely something about fascia that we are not going to figure out for a long time, that acupuncture and Chinese medicine, Ayurveda with their marma points figured out thousands of years ago. In that it affects the nervous system more than just holding stuff together. So this is kind of like a loose definition that they tried to come up with. It kind of works, kind of doesn't. So you guys are somewhat familiar with fascia, right? We got layers of sliding, collagen fibers, really different types of collagen fibers come together. The interesting thing is, so the innervation is actually pretty similar in structure to the skin. We have a lot of the same receptor types in different layers of the fascia, as we would in the epidermis down to the dermis and in the different layers of the skin. But they're trying to now get a little bit more specific with where each of those different types of fibers are actually sitting, and those receptor types are sitting. So we're looking at superficial fascia. We're actually thinking it's more to do with interoception. You guys know what interoception is, right? It's kind of like your own feeling of what's going on inside your body, your reaction to internal stimuli. Exteroception would be external stimuli. Proprioception is where you are in space. So we're looking at the different regions of the fascia that we're getting different innervation and feedback back from. And then the epimysial fascia, which gets down into the layers, and that'll include endomysium, perimysium, because they're all one. Getting down into the muscular layers, those actually have a direct relation to motor coordination and how we're actually responding to changes coming down from the central nervous system, but also going back in and just staying in the spinal tracts for how our motor movements are coordinated. And we see different layers of the fascia, kind of the function relates to their structure and their innervation and where they are in the body. I'll get into that stuff. I'm just trying to get to the boring stuff first. So lots of stuff happening in the fascia. We got different types of nerve endings. So the two pain type of receptors here, a couple of them here. We have the CGRP, which are the calcitonin gene-related peptides. So these are the peptide-containing ones. There's non-peptide-containing receptors as well that have pain. An interesting thing here is, so they're partly nociceptive, which is, we think that's the majority of their role, but they're actually quite important for mechanostimulation as well, and it's usually the noxious stimuli. So we have really light touch, so they're called MRs, low threshold mechanoreceptors. And those are usually more like soft touch, vibration, things like that we feel in both hairy and glabrous skin. Glabrous being like palms, and soles of your feet. But we notice that the CGRP receptors actually have a high threshold, so they're the ones that actually more relate to like deep pressure or pain, and that's why they're nociceptive, because they're responding to noxious stimuli. Substance P, we know about that, assumed to be nociceptive because it releases, pain-generating peptides as well. And then we have the TRPV1, which are super, super interesting here. These respond to the heat, acid changes, capsaicin, so that it also responds to that. Just like substance P is depleted by capsaicin, these receptors respond to capsaicin as well. Also ginger will activate these. So ginger oil or ginger essential oil will actually activate these, and it's postulated that that has something to do with actually changes in the fascia and soft tissue and ground substance composition that how ginger affects muscle tone. Yeah.
Is that just topical or is that internal as well?
This was directly looking at topical, that the gingerols in the essential oil were used. I would expect that internally they would work as well. Just how well are they going to get there instead of being used somewhere else? We don't know. So yeah, just a few things on there. Nociceptive endings here. Okay, so this is probably one of the more important slides that I do want to talk about and give you guys a little bit of information that we started to see this in the research last several years. Nociceptive endings, so HTMRs, high threshold mechanoreceptors, right? These are the noxious stimuli. They can also cause neurogenic inflammation. So not only can you have exteroceptive or mechanical stimuli from outside pressing or deforming those nerve endings or those receptors that cause pain, right? And you receive that pain. You can actually create neurogenic inflammation. So the nerve itself creates the cycle of inflammation and sends it backwards. So antidromic impulse, this is actually essentially backwards. So for sensory fibers, this would be stuff coming from the spine back out to the sensory nerve. So you get this cycle of inflammation, neurogenic inflammation, kind of going back and forth, and it essentially screws up the whole system. Some of the best research for this is in the thoracolumbar fascia, and it's hugely implicated right now in one of my least favorite terms, non-specific chronic low back pain. Side note, I'll get off the soapbox quickly. There is no such thing as non-specific chronic low back pain. You're just not assessing close enough. So if you guys hear that, just challenge people that say that and say, no, you just didn't get a good enough diagnosis. Either the person tried and they just don't know enough to get a deep enough diagnosis, or they just didn't care to get that deep. Hope that it's the doctor just, thought that was the best diagnosis, but it's not. Find somebody else who can get a more thorough assessment. You can always go deeper and find the root cause. Naturopathic guys, right? So, this actually happens a lot with disc herniations and pressure injuries. You get the inflammation, but this can also happen in shear injuries in the thoracolumbar fascia. You can also get sympathetic vasoconstriction due to an injury, now we're also getting into mind-body medicine, into your psychogenic or psychophysical changes in the fascia and the nerves and the receptors. We know that certain fibers, and I'll get to it on the next slide, C-type fibers. You guys have heard of C pain receptors or C fibers? They respond to pain, but they're supposed to be high threshold mechanoreceptors. They're supposed to be a little slower. They're supposed to respond to pain stimulation. Really interesting though, they also respond to light touch, and some of the research more recently shows that those actually respond to our mood changes, our behavioral changes to soft touch. So they have to do with that discerning between, a bug landing on our arm and kind of rolling around, and we're like, what is that? Versus like a mother's caressing touch. That really, really soft touch. And we're able to differentiate so many different subtle pieces of sensory stimuli that could be, smaller than even the size of the receptor field, but we're still able to discern. The C fibers, the C tactile fibers, sorry, that's the full name, actually have a little bit of role in that. And we're starting to see that the sympathetic vasoconstriction that comes with that psychosomatic piece could be creating some pain and neurogenic inflammation as well. So just a few more things like that. You can get the fasciitis. I don't know if I wrote it in here. I think it'll come up later. But the changes that happen with pain and inflammation in the fascia are systemic. They're not just physical medicine. This is why I think sports medicine or physical medicine is not just biomechanics or movement and structure. It is systemic. It's your whole body, because now think of this antidromic impulse. If you're having inflammation from the sensory neurons, you can get that same inflammation in motor neurons. So if you look at here, motor nerve composition, 43% is sensory and 40% is sympathetic, specifically in the thoracolumbar fascia. You got about 70% motor. So looking at that, if you have antidromic nerve impulses that are creating neurogenic inflammation, not just in the sensory nerves, but also motor nerves, where are the motor nerves going from your lower thoracics? Also think like splanchnic nerves going to your gut. Think leaky gut. Think gut inflammation, not just coming from food sensitivities. Think root cause. This could be a low back pain, chronic low back pain that was not addressed properly, having just unchecked cycles of chronic inflammation in the thoracolumbar fascia that result in inflammation of those nerves going back to the spine, going back out to the gut. Now you have inflammation. Now you have more fluid changes. You have decreased tight junctions. What do you got? You got leaky gut. Now you got food pieces coming through, poor digestion. All of a sudden now you're like, hey, I ate dairy for 40 years and now I can't eat it. What's going on? I ate, gluten for 15, 20 years and now I can't eat it. What's going on? I was always allergic. No. Are you allergic to it? No, you have a food intolerance because now your body's like, hey, I shouldn't be seeing full globular proteins in my blood. This sucks. I hate it. I'm going to fight it with everything I have and give you inflammation along the way. And that can change. You can reverse that as long as you find the root cause. Don't just take the food away and they never get to eat pizza again. That sucks. Have you been to Italy? Pizza's amazing there. Right? So think about those things. There's more to sports medicine, physical medicine than just pain, physical pain and movement. There's a lot more stuff I could talk about that. Quick thing I can note, anybody know about perineural injection therapies? Neuroprolo. You guys have heard of this? Right? That's what it's affecting. It's that neurogenic inflammation of very, very superficial nerves. They get pinched off coming through the fascia, whatever the reason might be. You put 5% sugar water around them. Just shut the nerve off and it turns on again. It's just like computers and phones and humans. You turn it off, turn it back on again, it works better, right? That's perineural injections right there in a nutshell for you. Very cool, very, very cool research coming up with that. All right, motor nerve composition, we kind of talked about this. We only have a certain amount of the myelinated motor nerves, and these are particularly sensitive to stretch loading. So now we're thinking like the spindles and Golgi apparatus. But again, sympathetic. We have ergoreceptors, so some are mechanoreceptors, and then some are basically what they're called is metaboloreceptors. So they sense the metabolic changes in the nerve or in the tissues serviced by that nerve, versus the mechanoreceptors are mechanical changes. And there's a little bit of, it's not very clear still, like a lot of this research in this area is very new. It's been done for like 30, 40 years, but nothing's changed in it. We're still trying to figure this out. There's an idea that sympathetics actually detect this. Again, sympathetic output, excessive, increased vasoconstriction, increased pain modulation, or increase in pain ambulation, or amplification, sorry. Potentially, ergoreceptors have something to do with that as well because they are sensing metabolic changes. And these are part of the motor nerve composition, especially, again, a lot of this research happens in the thoracolumbar fascia because it's this massive sheet of fascia. It's connected to so many different things, and it's easy to study because you can take biopsies of it without losing a whole bunch of tissue, right? This is super important. This is probably one of the most important things you can learn about treating injuries to myofascial structures. Pain thresholds change with eccentric loading of the epi and myomyciums, not the muscle. You're not actually treating the muscle when you're doing, for example, think tendinopathy, right? What percentage of tendinopathy is tendinitis versus tendinosis, would you say? Just a guess. Is the majority tendinosis or tendinitis? Osis, yes. Guess what? There isn't a diagnosis for one of the most common tendinopathies. Think tennis elbow, right? Lateral epicondylitis. There is no ICD-10 diagnosis for it. Of all the things that ICD-10 covers, all of those diagnosis codes, like polar bear flying through your windshield, seriously, there's diagnoses like that you can find for insurance purposes and stuff. And it's slightly different up here, I know, because slightly billing is different. We're not part of insurance system like in the States as we are here. But ICD-10 codes, you look at that, there's no lateral epicondylosis diagnosis. The entire medical diagnosis system is missing the true diagnosis of most tendinopathies. So tendinosis is the most often the case. The chronic, low grade, no inflammation, it's just degeneration of tissue that results from overuse, injury that wasn't treated properly. Eccentric loading is one of the most effective and important treatments to do immediately for that, starting right away. And you're not actually affecting the muscle, you're affecting the epimysium and the myomycium, which changes from the nerve receptor point of view, the pain threshold, which allows you to do more weight, which actually changes, now you're looking at the endoskeleton of the cells, and you're creating those force changes, which results in those tension changes, which results in creating proper collagen formation, right? So you couple that with cross-fiber friction, there you go. The top two most important things to do for any tennis elbow that's not acutely injured due to high force injuries, right? So people that come in working on the computer all the time, you know, overuse for years, they kind of get worse and worse and worse. Two things you do: cross-fiber friction and high load eccentric training on that muscle, and that's probably the most effective thing you can do for them. Yep.
I thought that the theory behind the eccentric was that you were like stretching out the tendon, like not necessarily the muscle, and that was causing the like laying down the proper angle.
Yeah. So hold that thought,
Okay.
because the fascia talk, I'm gonna bring that in because again, the epimysium and the myomysium combine with the endomysium and they form the tendon.
Okay.
They are actually one contiguous structure, but it's not actually the tendon either. So the research really shows that we're affecting what's called the paratenon, the epimysium essentially of the tendon. It's the paratenon that's getting affected with cross-fiber friction and these force changes. Yeah, the tendon, you won't stretch. If it stretches, it rips. It's just, it's so stiff and strong. The actual tendon proper is not going to be what stretches and changes. It is actually what we're seeing more and more. This research is showing is that it's the fascia. It's the fascia that surrounds the muscle, that surrounds the tendon, that surrounds the ligament, that actually creates some of these changes. We can almost consider certain areas of fascia, with certain structures, like the satellite cells for muscles. They are what support it. They likely hold and they house a lot of those mesenchymal stem cells that sit around that we stimulate when we do stem cell injections. You know, when we get either bone marrow aspirate or fat aspirate, and we inject those stem cells. The stem cells actually aren't just regenerating the tissue. That's not actually what we're seeing with the research. This is regenerative injections, little off fascia, but kind of connects. What we're seeing is that actually changes the environment that injury is in, and it helps regulate the stem cell environment, helps regulate the cofactors and the signaling in between all of the cells, which stimulates your own stem cells to start working properly, and then that starts to heal the process. But it's likely more so coming from the fascia that starts that process than the tendon. Yeah.
And you said high weight, so we're going low rep.
Yeah, just a handful of reps. So think like eccentric. The best way to do this is like you would rest your arm, you know, like on a table, and you grab a dumbbell that's hard enough that concentric contraction is tough, like almost impossible. And you would bring it up with the other hand, hold it there, and then just slowly let go. And you would do maybe 5 to 8 reps, right? Let go, relax it, do the cross-fiber friction, right? You're kind of separating out those straws. The way I always explain this when I'm doing it to a patient, because they're like, this hurts, this sucks, I hate you, why are you doing this? And I say, look, when you injure your tendon and it's trying to heal, it's like throwing a bunch of straws on a table. Do you want that to be your tendon? No, right? When I do the cross-fiber friction and then that muscle contraction, it's like raking those straws. Now they're all in one direction, and they can only be pulled in one direction. You pull a straw from side to side, it bends, cripples, falls apart. Same thing with collagen. It's only strong in the tensile force. So that's what we're doing. We're breaking those connections with the cross fiber, and then that strong contraction is laying them down. Yep.
I read that for lateral or medial epicondylitis that you could do the eccentric but at different angles. Do you do that with your patients? Like 90, 120, 180?
You can. I don't end up doing that because it's just like usually the eccentric training is happening at home. So more the in-office treatment that I would end up doing is more of the cross-fiber friction. If I have access to it, extracorporeal shockwave therapy, low energy shockwave, because that is phenomenal for it. If you guys want me to talk about that for a few minutes after this, I will, because more and more research on that is super cool. Not just for lithotripsy, it's awesome. But you can change the angle. When we look at the biomechanics of those muscles, either of those, because they attach above the condylar ridges, right? They're on the supracondylar ridges. When we're doing that flexion extension, we're going to affect a very small area of that tendon or that myotendinous junction that's moving. Some of that tendon will be moving. The myotendinous junction doesn't go through a lot of different range changes there, right? Compared to, for example, like the biceps. When you go through the flexion extension like that, that myotendinous junction moves significantly in angle and in force production with different angles, right? We know 100 degrees. That's where it's strongest because it's in the best position with the Frank-Starling laws with the force length curve, right? With the elbow, because it's such a small area, you won't get a significant change in how far that tendon is being pulled and how much change in that myotendinous junction is happening. Because that's usually where the injury is, right? MTJ or directly on the enthesis, right, where the tendon is attaching into the bone. Usually the MTJ though, because it's the weakest junction. It's where you go from one tissue to another and you have to connect it with connectors instead of just one continuous line, right? So there's nothing wrong with that, I don't think. If they have the time, if they're up for it, yeah, get them to do all different angles.
When you look at something like, say, the quads that are all, there's like three or four different muscles that are joined to make one tendon, is that more when you would do like different angles to challenge, do the eccentric
So
loading?
you could, yeah. So with the quads, it becomes a little bit interesting. If you're actually, are you working on like the quadriceps tendon or the patellar ligament, right? And I say it specifically like that for a reason, right? The quadriceps tendon goes into the patella. Patellar ligament comes off because it's bone to bone, right? Usually injuries in that structure happen in the patellar ligament. In that case, again, you want eccentric loading. A lot more difficult to do eccentric loading on that joint without stressing the actual cartilage and joint areas, right? Like we know, knee extensions is the single worst exercise you can do for your knee, right? It changes that open kinetic chain exercise for that knee. Open chain being, you know, what's supposed to be stopped is not, and it's moving the foot and the rest of my body is open, right? Easy way to explain it. It's not a good exercise to do for that knee in general, for that knee joint. So it becomes a little bit more difficult and you end up doing a really dynamic movement, such as like a Bulgarian split squat, going down into eccentric movements. That is gonna get all ranges of that quadriceps. So you don't really have to worry about that, right? Yeah, because the hip, where you're at the hip, we're moving that, doesn't matter. It's so far off, it's such a long muscle, there's so much that happens in between that you're not gonna change what you're doing here if you change the angle of here while doing this. Yeah. Cool. All right, proprioception, couple quick things. This is really interesting. We see these CGRP receptor endings might actually also have a proprioceptive function because we see them in high density in retinacula, low density in high muscular tension areas. Because we don't want to feel pain when we're pulling hundreds of pounds, right? In those really high density, high muscular tension areas, like biceps spondylosis, they have really low density. That makes sense. Every time you do a bicep curl, you don't want to feel the pain of that deformation. But in the retinacula, say your carpal bones aren't in the right place, right? If they're shifted, you feel it right away. Your wrist hurts, right? You lift your backpack wrong with the wrong angle on your wrist. That's going to hurt your wrist and you're going to feel it. So potentially there's a proprioceptive function for these receptor endings as well. Again, not very well elucidated. There's so much that we don't know about this. But we also see this, that we see a higher density of these along with a higher density of fibroblasts in areas of injury. So for example, like frozen shoulder, you see the same changes in the fascia around the frozen shoulder as you do in chronic low back pain sometimes. It's almost like a frozen lumbar piece. You might not get that adhesive capsulitis from the intra-articular point of view, but the fascia becomes more adhesed. You get more connections between the layers, less sliding, you get a higher density of fibroblasts and a higher density of CGRP endings. So it's more painful to move, so people don't move. You don't move, it gets more stiff because the body says, I'm lazy, I'm going to do exactly what you tell me, no more, right? That's what always happens. You don't exercise, your body says, I'm going to do exactly what you tell me, no more. Not going to adapt to anything more than you do. So what we're starting to see is the high number of adhesions will impede the proprioception even further. You're getting less sense back because the fibroblasts disrupt the proper nervous input. And so, but what we know is, and this is probably a huge practical takeaway, proprioceptive input directly inhibits the spinal cord processing of the pain. So, if we increase proprioception, the pain goes down. But if we have high pain and we're not moving, proprioceptive function decreases, and that proprioceptive input that's inhibiting this also decreases. So you get further amplification of nociceptive function in the fascia. So you get that cycle. You get that chronic cycle of pain, no movement, inflammation. Life sucks. So one of the best things you can do is increase proprioceptive function. And the easiest way, simple exercises, will increase proprioceptive function, will teach the body where it's at in space, and all of a sudden you've got an inhibition of nociceptive functioning, right? So you don't process it from the spinal cord level. This is not CNS, this is spinal cord level. And now they're like, oh, that must have helped my back pain. You say, sure, because we don't know what the root cause is yet. We don't know what caused the inflammation. But now you can go down that route and saying, okay, let's do some more actual rehab. Let's treat it. Let's get you moving. Let's peel the layers of the onion. No pun intended with the fascial layers. But you peel the layers of figuring out what's actually going on, get your diagnosis, bottom line, get them moving. You know your body, where it's at in the space, you can feel it, you can do more. Tactile C fibers, we kind of talked about this really quickly. I'll let you guys know the interoception and proprioceptive part. So body work. We actually think that like our visceral manipulation, craniosacral work, Bowen work, all of that is actually probably affecting some of the tactile C fibers. And not in that high threshold, but the low threshold mechanoreceptor function. And that's what changes your mood. You come out of massage, I feel wonderful. I feel so good. I feel happy. That's that interoception. You're getting positive input. You're getting this pleasant touch through your skin and your fascia. And it's likely that this is happening in the superficial fascia that we're feeling this, but also in the deep layers of the epidermis. So there's been a lot of research. I was at Fascia Congress 3 years ago. I wasn't able to go to the last one, which I think was last year. Got more interest in other things. But fascia is a wonderful, wonderful thing. We're going to have endless amounts of research continuing on with it. If you're interested, Fascia Research Congress is definitely one place you should go and look into. Go as a student when you go for conferences. You get fantastic discounts. And meet as many people as you can. Like, I met some incredible people at the Fascia Congress, got to see them do their work firsthand, explain their own theories and their own work firsthand, not hearing it through somebody else who read their book after it was explained by somebody else. Things get lost in translation, right? But hearing it from them directly and seeing some of the newest research that they're doing, super, super cool. And we talked about this. This is really interesting. Anybody who's super interested in fascia here? Like, looks at research or is really interested? Yeah. Sergei Grakovetsky. He's a researcher, and he talked about some really, really, really interesting stuff here. So what we saw was that, first of all, there's a triangular ligament that actually stabilizes the abdominal container. It stabilizes the abdominal fascia with the erector spinae group, right? So if we have really bad drawing, guys, don't. So this is like the abdominal wall. Let's try this again. This is like the abdominal wall coming in. This is the posterior side, and we're looking like cross section, right? And you have basically the bump out of erector spinae, like this, and then it comes and attaches here, and then you have your spine, right? What we see actually is that anatomy books miss this all the time. There is a ligament right there. It's called the triangular ligament. It actually stabilizes your core. That is a very, very important piece of your core. So when you pressurize the abdominal container, when you stabilize the internal external obliques, which are more important for your core than your rectus and all the other muscles that look good, that pulls on this triangular ligament. It stabilizes your erector spinae, which stabilizes your spine in a neutral curve. So it doesn't move out of that neutral curve where your discs are happiest. That's where your back can take the most amount of force. What Grakovetsky was talking about was that the fascia might actually have such a role in locomotion in that there was, he looked at some studies that showed that people that don't have any limbs, all 4 limbs are gone, can ambulate on basically their ischial tuberosities. And his idea was that the fascia actually changes to modify the locomotion happening from that. This is the same idea that goes into fascial slings, you know, anatomy trains, anatomy lines, meridians, probably all the same thing. Different names for it, right? But what we're seeing is that it actually minimizes the loading on the skeletal system. So when you put certain forces in vivo, when you test people physically, they can hold way more force on their spine, on their disc, on their ligaments in the low back, in the lumbar spine, than should be biomechanically possible for those individual structures, even combined, summed up the forces. And really what his big suggestion is that it's the myofascial system, the thoracolumbar fascia, specifically in the low back, that's taking the excess strain. And we can't measure yet how much strain it takes and where it goes, because it disperses it through these lines that we can't really see very well. We can dissect them out a little bit. We can't test them in somebody. So really cool, because we're able to move way more force and generate way more force through our body than should be humanly possible on these structures. Like an ACL, in reality, a soccer player should tear their ACL in their first game. Like any, like above 12 years old should tear their ACL immediately the first time they stop, pivot, and run, right? We don't. Is it the muscles? That's what biomechanics research will say, that it's the muscular system that's doing that. But the forces on the muscle is insane. That is way too much force for just muscles, especially not insanely well-trained muscles to be able to take, and the tendons to be able to take. It's likely that the fascial system is taking on the stress that we don't know, and that's what gives us our borderline superhuman ability to move force. So super interesting. Tendinopathy. That's what. Tendon or paratendon? What we're seeing, and this was the research was best done by the Steccos. You guys familiar with Stecco family from Italy? Are you guys familiar with fascial manipulation, the courses? They're from Stecco. Luigi Stecco is the guy who started. He was a PT back in Italy. He still is, but now his son and daughter, Carla and Antonio Stecco, they do some of the best research on fascial areas. He's done incredible fresh cadaver dissections. So this is like immediately fresh dissections, thousands and thousands of times, and is basically confirming a lot of what the meridians, the acupuncture meridians, Ayurvedic marker points, Tom Myers' anatomy trains, a lot of what they said, he's kind of confirming and showing why that stuff works, and is actually finding different patterns that we didn't even know existed before. And he's actually confirming nervous system-based reflexes through the body. For example, you guys know like the withdrawal reflex or the cross extensor reflex? There's actually a spiral fascial line through the arm that comes back and connects into the torso that actually is implicated in, it basically acts like a spring, and it springs back in the same way that your muscles in your arm would reflex in basically a poked withdrawal reflex. Fascinating stuff. They're doing some of the best research. They've done it for the last few years. Their method, the fascial manipulation, is cool. Not the only way. The way they talk about it is it's a pretty painful fascial manipulation technique. They talk about different centers and different muscles and fascial points that are actually the areas where fascia basically gets adhesed. And so if you release just those areas, the rest of the line will let go. Those points almost perfectly fall over meridians and acupuncture points. Very close to Ayurvedic marma points as well. Like it's uncanny how well they fit together, and their lines follow anatomy trains. They all fit together. So it's like not the only way, but some interesting research on what temperature you have to heat up hyaluronic acid when it solidifies, because that's one of the pieces of the ground substance that solidifies. Basically, they say you have to get to 43 degrees Celsius to warm up locally for that to liquefy again. And then if you do it at those centers of coordination, CCs, the whole line lets go. Yeah?
What was the name of that research again?
So it's from Stecco. Stecco is the researchers, and they're great practitioners as well. They have an interesting system. There's actually a really good Stecco practitioner and teacher in BC here. I can't remember her name, but she's a chiropractor. She teaches these courses, and they're interesting courses. A good friend of mine, good colleague of mine, does a lot of it. I'm not the biggest fan of doing it because I have other tools to do the same thing basically. But as far as the research goes, and the fascial research they have, their book is phenomenal. So, yeah.
I have a question.
Yes.
Is there any research showing like trauma being held in the fascia?
So I'm not aware of any research specifically being able to show that,
Yeah.
but we do know that the fascia changes with mind-body approaches. We have seen changes in ground substance and the sliding of fascia and the malleability of fascia with just mindfulness-based meditations or various meditations. So I think it's still trying to be elucidated on how we can tell where, like whether we are holding emotional trauma in fascia. I think some of the research with the neuro-based research with fascia is probably going to be the closest we're going to get to elucidating that, because we have to translate that in some way. The thought has to get translated from an abstract thought to a chemical, to a electrical signal in some way, and that's going to get translated in some way to a mechanical signal. We just can't find the pathway yet.
Do you think we can go the opposite way?
100%.
Like
100%.
work and then
Yeah, because we see that all the time. We see people have releases with body work. We see people that have emotional releases with movement therapy, right? With yoga. Neural therapy. You guys familiar with neural therapy? So that's when you use like lidocaine or some sort of anesthetic, and you basically open up scars, old scars. One of my mentors, one of my closest mentors, who's taught me probably the most about phys med that I know. He works out in the States. He's an NDDC, LAC, everything. When he first started doing it, amazing, super brilliant guy, but he was like, he had this patient coming with a mastectomy scar. And it was a long scar. And he was like, oh, he's like, I can release this. You're going to release all your back pain is going to go away. Like, I can trace this. He's phenomenal. He can like look at you and he'll measure your ears. He'll look down like your entire body, and then he'll step back, and in his head, he already has the entire map of your body like mapped out. He knows exactly what's connecting. It's brilliant. But he saw this and he's like, okay, that's what I have to do. So he released it, and he released almost the entire scar in one treatment. The patient came back next week, was horrible. She was like, I can't walk. I can't move straight. I stand up and I stumble because I can't actually control my body. I feel like I'm drunk. I'm an emotional mess. He completely destabilized the function of the fascial system from just releasing that scar. So we know that these adhesions, right? Think one big saran wrap, right? We pull here, everything feels it, right? So with neural therapy, you want to release little bits at a time, but we see that. We release too much, you get these huge emotional releases, right? We can put the two and two together, but as far as getting a randomized controlled trial to show that, might be tough. Yeah. So the last thing was myofascial slings. I kind of talked about it, but I would say this is probably the newest name on the block. This is the new kid on the block as far as the names for anatomy trains, meridians, anatomy lines, fascial planes, whatever you want to call them. It's really interesting how well they correlate with each other, and I think there's so many different ways of using this. For example, when we look at basically, so everybody familiar with what fascial slings is? Should I explain it really quickly? Basically, it's a line that you can find and you can even dissect out that's continuous, either functionally or structurally, of muscle and fascia and connective tissue that runs through different parts of the body that aren't normally connected. So we know that one runs from the shoulder, so in the back, we have this cross that goes around the back. So if we're looking at somebody's back, the right shoulder will connect to the left hip, and that will connect the other way, and it actually controls locomotion. We know that even, interesting fun fact, because I'm filled with these sometimes, Julius Caesar, in his writings about why his armies could march forever, and they were known for being able to march for days, get to the battle, and still be full of energy and be able to fight, was because he specifically trained them on how to march properly. It was a very, very structured march of equal arm and leg movements back and forth. What are you doing? Think kangaroo. When they hop, it's actually easier for them to hop than to walk. Why? Because that elastic energy in their Achilles tendon basically stores up so much energy that it just propels them along. Same thing with our thoracolumbar fascia. It's elastic, so when we move here, we're stretching that tissue, and it actually propels us to swing back this way. It actually protects the spine and keeps it in a neutral position so we can use less force to move. So arm and leg swings, super important. Also, we know that from the research of like Stuart McGill, for example, father of low back mechanics, doing that with disc injury patients will actually take compressive force off the disc and will take shear force off the disc. It'll be less painful. They can move. Walking faster is better for your discs than walking slower. So when you tell your patients that are old, they're 75, 80, and they're like, I walk a little bit, I can walk a bit, but I can only walk so far, or I want to start walking. Don't say walk slow. Say walk as fast as comfortable. Walk faster instead of slower. Because your discs will thank you and your joints will thank you. Because when you get into that movement, your fascia takes over. And you don't have as much compressive and loading and push-off forces because you get elastic energy stored. So that's probably one of the coolest things about these slings that we can use directly in therapeutic uses and practical application. But also, this was really cool. I actually saw Tom Myers do this in the actual Fascia Congress when he was doing a hands-on treatment. He released the entire deep front line of somebody working on just their shin. And so what you can do, say you're working on a deep fascial line. So we know that the deep posterior compartment of the shin connects to basically the deep muscles of the quads and the adductors a little bit, comes up through the deep core muscles, the deepest layer, and comes up all the way to the actual longest colli and longest capitis, right, in the neck. And so when you work on the deep posterior compartment, the septum in between the deep and the superficial posterior compartments of the thigh, you can get engaged to it and have the patient just move their head up and down, and you will feel the changes in that septum in your fingers without having to dig in and treat more of that septum on your own. You engage the system. You engage both the sensory and motor input into that tissue, and now they're moving. If they move and their body moves, it will work way better than you trying to move it for them, no matter what. Always, every single time. Movement will fix them faster than you moving them. So you get them to do that, you get them to do a half sit-up, you get them to start flexing their leg as they do it, and everything changed. The range of motion changed really within 5 minutes. Ankle range of motion completely changed. They were able to move head back and forth. The strength improved for sit-up strength immediately. Really cool stuff. So you can use these myofascial slings or anatomy lines for treating different parts of the body. We know that if you just work on the plantar fascia, warm up the plantar fascia, you will get a better toe touch because you warmed up the entire superficial back line. So there's a lot of stuff you can do here. Anatomy Trains is a great place to start. Tom Myers has some great information. It's all free basically online now. He offers everything straight up.
What's his name, sorry?
Tom Myers. He's a massage therapist who did a lot of work over the years putting this stuff together. He's done a great job putting information together. And yeah. Any questions? No? Yeah? Yeah.
So I've heard of, it's not like a pin and stretch fully, but like pinning muscles down and then moving through range of motion and doing that before you work out. Is that similar to this then? Like I'll do that sometimes with my biceps or whatever it is.
So it's almost like an active release, right?
Mm-hmm.
And I would say that it's same idea. You're pinning the myofascial system in one place to create movement somewhere else, right? Movement is life. Anything when it's not moving is going to be worse off, right? Essentially, unless we want stability. But that's the same idea. Is that you're likely warming up the myofascial system as well. We know that just moving the shoulder joint will increase synovial fluid. Released into the joint, and that joint change, we have mechanoreceptors and proprioceptors that will say, oh, I have more fluid, I need to be moving better. That might just change that fascia on its own as well. But I use active release with patients all the time because again, you pin it and get them to move through that movement. You're also getting basically your reciprocal inhibition coming in. You're using the nervous system, you're using the muscles to teach it. Your body will never keep flexibility that it doesn't need. So if you just stretch somebody's hamstring out, but they don't have the quad strength to use their leg in that range of motion, useless. They will tighten up that hamstring immediately again because they don't have the ability to use that range of motion. You will only maintain functional range of motion. Otherwise, stretch all you want, nothing will happen. You have to strengthen it and reduce. So, yeah. I was going to talk a little bit about it. I didn't get a chance, but I wanted to talk about kinesiotaping, because I mentioned that I wanted to start teaching some kinesiotaping classes in Canada for naturopathic students. So who here is familiar with kinesiotape? Kind of know what it's about? So yeah, super useful for sports med, phys med, we know that. I use it for like the primary care stuff all the time. For example, if you're able to get somebody out of pain immediately, and then they start doing other movement, they start exercising, or they start doing whatever else you wanted them to, that's a huge bonus. Even if it is a temporary symptomatic relief, you are getting them to do something else. Symptomatic relief is important, right? It's important to treat symptoms while the patient's trying to treat the root cause, right? So kinesiotape can help with that. I've also seen some amazing treatment things happen with just kinesiotape because it's directly acting on the fascia. Some of the newest research with kinesio, when I took it, was their old model. When I originally took kinesio, they were talking about muscle inhibition or facilitation, this and that. They revamped their entire program when I went through instructor training, and they realized we were wrong. The kinesiotape is not doing what it's supposed to be doing, and that's why I like kinesiotape as an organization. It's the original, does the most research, probably the most important training in the actual training their practitioners. And they looked at it, and most of our effects are probably coming from nervous system effects. So they looked at the different receptors in the skin and which ones they're affecting, based on how much tension, based on how deep the tape is acting, and why when on ultrasound you put a piece of tape, the fascia moves, and then you see the muscle move underneath. You can see that in ultrasound studies immediately. But the tape can't act on the muscle, we know that. So what's going on? It's likely the neurofeedback from the skin, from the fascia, that's changing this motor output. So that's why I really like it. It's a cool tool to have in your toolbox. Again, from a naturopathic scope, being able to know why you're using it, right? I use it a lot in athletes for acute care, like an athlete comes out and they've hurt themselves and they're like, I'm still gonna play. I've had a Gaelic football player come out and say, yeah, I probably have a broken ankle. And I said, yeah, you probably do. I look at it. It's probably broken. He said, I'm gonna play regardless. So what are you gonna do? I was like, okay, I'm gonna make sure that you don't damage it more. That's where something like kinesiotaping and other sports medicine stuff can come in handy. And I would like to off the record, I'll probably teach some of that stuff too if people are interested, because we want to know more than just one thing, right? So Larissa will have all the information about that. Rita will have the information probably too. You guys can figure that out. I'll try to get a flyer to you on information I think I've already sent information over. We're probably looking at like first weekend of January, so you guys can avoid it of exams, because otherwise it'd be like December. I'm like, I don't want to give you guys a weekend course. It's a 16-hour weekend course. You get your workbooks, you get your tape and stuff, and I would come up here and we could teach it, and with some phys med tables, massage tables, and have some fun.
Probably going to be January 5th or 6th, which is a Saturday, Sunday, after the first week of school. I'm going to get a flyer out to you guys ASAP, but we need a minimum number.
Yeah.
This lovely man's going to drive all the way back to Canada to teach us. We want to have a good turnout. Turnout's the word.
There you go.
Good, I'm not the one talking. So if you guys can just let me know who's interested, I'm going to put something on Facebook again. If you can just comment your names or shoot me an email, come talk to me, whatever it is. Just let me know, because again, we do need a minimum number. And if you're confused on what the heck it still is, he's teaching it, so ask him some questions.
Cool.
Thank you.
Thanks, guys.
Did you ready? Send a copy of the PowerPoint to the Thank you very much.
Yeah.
Oh no, that's battery's low.
Awesome. As long as it didn't stop filming, because we're sending this off to Toronto.